the video, but I'm really thrilled to have this collection of amazing souls on our last panel and to talk about the future of healthcare. And I mean, no pressure at all, but basically you're all just predicting. So hopefully it's a good prediction. Hopefully it's sending us on a good trajectory. So Olivia has agreed to be my sidekick for all of these, and I'm so appreciative. I will let all of you introduce yourselves because you can do a much better job than I can. And I actually love that not everybody here knows everybody. So that's even more fun for me. So I'm going to go ahead and just kind of go in the order that's on my screen, so I make sure that I'm on track. So Todd, you were on first, so please let us know.
For sure. My name's Todd Otten. I'm a family physician, co-author of the book Ripple of Change, and then I do a lot of work with Medicine Forward, and recently have a part-time job with emergency care specialists. And I joke that predominantly I'm just a troublemaker.
Perfect. I'm so happy I chose you to be here. That's exactly what we're looking for. Nobody here should be interested in the status quo. So, all right, Olivia.
I've done this so many times, I'm still awful at this. So I'm an entrepreneur, a healthcare consultant, and physician advocate overall.
I love it. It's like you could reinvent yourself every time and just
I have to, because I'm just, I don't know, I'm just whatever.
It's anarchy at its best. All right, Jason.
I'm Jason Gutman. I'm a wellness coach, and I think relevant to this group, a neat way to describe what I do is we all know the importance of lifestyle medicine. We all know what can be done if people eat better, exercise more, and otherwise take great care of themselves. My job is to help people actually do that. So we're not talking about statistics and infographics and all that kind of stuff, but getting people to actually do it.
Amazing. Amazing. And that's a great segue into Mark, because he is exactly what we need to wrap it all up.
Yeah, exactly. So my name is Mark Jacobs. I'm originally trained as a medical psychologist, but I've been modeling and doing data science for the past 10 years as an independent consultant. I've written 2 books, one on using models for policy and the other one on AI, but really advocating human intelligence instead of just a technological processor. So just, appreciating what we have as humans and still looking for what technology can offer, but definitely not let technology, dictate how we do our work and what we do. Which is, of course, completely an opposite than what you see now with the hype. And this is what I talk a lot about with Liv. And this is also, I think, what brought me here. So very nice to meet all of you. And that's a little bit about me.
And where are you calling in from, Mark?
Oh, I'm from the Netherlands.
Amazing. I love it.
Yeah.
We're international. Yeah. That's just how cool we are. Okay. I mean, we were already international with Olivia. Now we're like super, super robustly international.
I'm just making us go further out into Europe.
Exactly.
trying to even the playing field here.
I love it. Okay, so this is really, it is anarchy at its best. There is no script, which for some people might be a little bit nerve-wracking, but honestly, what I would love is just for a collection of humans who really want to impact and implement change to come together. So nobody on here has been given a script or any direction at all, except please show up at this time, and they all did. And so I think we're already winning. So the goal is to just start the conversation and sort of let it go as it will go. And so I will start it off to the group, and whomever wants to answer this question is free to do so. And it's really the question I ask now at the beginning of all of my podcasts, which is, can healthcare be great? And if so, what is the biggest challenge in making it be great? So please, who would like to go first?
Well, I guess I'll jump in on that one, because yes, healthcare can be great. And I'll speak from experience, I suppose. I've seen it work. I've seen it work with individual patients. I've seen it work at the office level, the hospital level, the ACO level. And I think the thing that, simply put, we need to consider flipping the script on is putting people over profits, particularly in the United States. But that focus on whatever fiat or currency you might use has created so many issues and condensed the time visit and eroded that trust, and it has just led to a whole host of negative ripples, if you will.
Yes, and I love that you have firsthand sight and knowledge of the potential for it being great. Jason, you may have a similar experience with seeing the change that can happen. So feel free to chime in.
True. I mean, I often describe myself when it comes to this stuff as anti-cynical, because I see so much good stuff happening in front of my own eyes every week. And particularly I see what people can do when given adequate accountability, guidance, and support. So is it happening at scale in the way many of us would like it to see? Probably not, but can it happen? Absolutely. I think a couple of things I would add, Claudia, is some of this is in the spirit. I actually looked this up just to make sure I got it right, of this Buckminster Fuller quote, which is you never change things by fighting the existing reality. To change something, build a new model that makes the existing model obsolete. So to answer your original question, I kind of answer it with a yes or a no. Can you take the existing medical system and make it great? I sometimes doubt that. I think maybe there's too many layers and layers and layers of bureaucracy that are invested in staying the way they are. But can something else be created that eventually replaces that? I think everyone in this conversation is doing that, and I think there are many more people doing that. I think it's happening. I think it's just going to take the time it takes.
Without a doubt, I don't think anybody would argue that the existing infrastructure is a complete mess right now, but there are pockets of things that are going well. And I could point to some examples, and maybe we can get to that a little bit later in the show, if you will. But there are a lot of individuals that are trying unique and innovative things to deliver better quality care at lower costs without taking those antiquated models that frankly aren't working most of the time. A good example is the work I'm doing with emergency care specialists. They're creating a brand new type of clinic to meet the need between an urgent care and the ER. At a lower cost, staffed by emergency physicians, tons of capability. It models the quintuple aim or the quadruple aim or whatever you want to call it. So yeah, I think there's pockets of very cool things happening. And to go back to the comment on scale, we've got to take these things that are new and working and then celebrate them on a big scale. That's really what needs to happen. I am frankly sick and tired of everybody saying, oh, let's do lean this or Six Sigma this, or let's make it more efficient. Frankly, excuse my French, but I think a lot of it's bullshit. We don't work on an assembly line. It's one human being seeing another human being. Forget about everything else, all the noise. Focus on the person in front of you. Take some time, do what's right, listen. What did that take? All of 5 minutes, and I had an expletive. I had done so well on podcasts, not swearing.
I never promised it was going to be family friendly. Although now when I put it on YouTube, I guess I have to say it's not for kids. I don't know. I don't know what the rule is.
That Dr. Otten, he's always throwing something out there with a 4-letter word. I swear.
It's always the French. They're always cursing. I don't know what that's about. I don't know much about that.
Do you know what? I've never actually heard a French person swear. Honestly, I think the English swear more. I'm going to hold my hand up and say it's us.
And when they do, it still sounds beautiful, huh?
Yeah, it does.
Of course.
Way more beautiful. Well, let's let the international, the robustly international folk chime in. I guess we hit a little bit, Mark, on systems, and so your field is like probably as far removed from what I know, like close to car mechanic stuff. Like I don't know mostly anything.
Yeah, it's funny because what Jason was telling to me. That sounds like vision, huh? So if you try to change something based on what's currently there, then to me that's not having a vision. That's for me trying to see if there's a next step. But it's to have a vision, you have to break something. You sometimes have to break something. And what I see in healthcare, especially now with all the AI and all the modeling and things move so fast. I'm actually looking at my Zoom, and now I see for the first time there's like an AI companion that asks me, do you want to enable this AI companion? when you look at least when I look at healthcare, I see so many ways in which healthcare is trying to measure itself. Everything that is being done has to be almost accounted for, has to be measured, has to be put in a model, has to be put into a lean system, has to be put into agile, has to be put in a post-it. And then at a certain moment when you have these kind of things, then it's like if you build a sort of, a parallel healthcare system that has nothing to do with healthcare. It's management, it's measurement, but it's not caring. And so for me, what I always find, I mean, there's an example. So I saw an example 2 days ago of a system in the Netherlands where they use models to predict if somebody can be sent to the ICU or discharged from the ICU. That's now a big thing in the Netherlands. And those people got 4 million for the development. And we only have, I think, like 100 ICU, 1,000 ICU beds in the Netherlands. It gets less and less and less. So that was a lot of problems in COVID times. And I asked them a question. I said, how many ICU beds and how many nurses and how many could you actually buy for that 4 million? And of course, I got no answer because, of course, it's technology and we have to keep inventing. And so for what my problem is that, yes, it's okay if you build a system, but it's not okay if we are now nurturing a system instead of the patients that inhabit that system. And so that's always been my problem. And that's what I see with technology, where technology should be to enable humans to do better in caring. It is actually we start caring for the technology that's being used to care. But it's my personal opinion, so I mean, it's what I think.
I love your opinions.
Yeah, I know, but not everybody.
I think you're in good company here, Mark. I see a lot of heads nodding in the right direction with regard to what you just said, because I think we're all on the same page with wanting a return to genuine humanism in healthcare. And that's the concern with where we're headed from a technological space is how do we maintain that? And where are we investing our resources? Are we investing it into humans, or are we investing it into, just the rocket ship of tech?
I'd love to chime in on this. I think there's so much we can unpack here regarding the investment in human capital, if you will. I think I listen to all these things about tech and AI and what have you, and I go back to the most powerful prescription that I wrote for my co-author, Joshua. It had nothing to do with medicine. It had nothing to do with a referral. It was just right. He was struggling so much with his healthcare. One of the turning points is when I told him, I believe you will get better, but you have to believe it too. And that was a complete turning point to the trajectory of his healing. And that's not going to come up in an AI algorithm for me to offer to him as a prescription. There's no way. So I guess my point is, we've got to get back to the core of what healthcare is all about, and it's human beings. And I can't stress that enough.
Yeah, I often wonder why it seems that is such a difficult thing. Because in its basic form, caring is not that difficult.
I think part of that, Mark, it has to do with all the additional pressures that have been piled on to clinicians, and it's created this tremendous time crunch. And you're trying to accomplish a ridiculous amount of tasks in 15 minutes. And that compresses that human interaction to the point where it's so transactional anymore that you're not really accomplishing a whole hell of a lot, to be quite honest with you. And until we can unwind that and get back to people over profits and really understand that value component to healthcare delivery, it's going to be a bit of a struggle. And I think so trying to model things on the existing infrastructure in my mind, is a complete mistake.
Hmm.
We have to think outside of the box. We've got to blow up silos. We've got to try new things, and we've got to be okay with some failure at times too. Like this idea that it's perfectionism that's created a whole host of other problems. Like as a clinician, you can't make a mistake ever. That's ridiculous.
Yeah.
We're all human beings, but I think the key to that is if you make a mistake, you've got to own it. You've got to be transparent about it. You can't bury it under the rug, all those kinds of things.
So then I wonder, if I may, both Todd and Jason, but also the rest, is at least in the Netherlands, this is kind of funny because now you go international, you see also differences in healthcare systems and what's going on. So in the Netherlands, there's a growing group of physicians that believe that technology, especially AI and large language modeling and things like ChatGPT, can give back that time that you described of having to do a lot of stuff in a short amount of time. The technology can give that back. So caring with technology, caring is about caring again. And I wonder how the rest perceives that, because I'm not a physician,
But see, Mark, there's the problem, because I can't remember if I actually even spoke to you about it. Like the CEO I spoke to when I approached the AI thing with him and was like, look, everyone's on this bandwagon right now and saying, look, if we bring AI in and we reduce the paperwork and we reduce the time, we'll give the physicians back more time to spend with their patients. So the doctors are all over it and nurses are all over it. Are you going to let them? And he was like, obviously, long story short, but he's like, professionally, no, I can't, because it's my head on the block. And, my job is to put through as many patients as I can. There is a bottom line here. And I actually do care. I really, really care about my staff. Like, that's it. But at the end of the day, if I do this, I'm going to get sacked and they're just going to bring in somebody who doesn't care. And it's still going to push through more people.
Yeah.
So you're like, well, okay, well, what happens then? So you guys bring in more AI, it reduces paperwork. What happens? He's like, well, what will happen is a physician, instead of having the break to do the paperwork and do whatever, is going to go patient, open the curtain, next patient, open the curtain, next patient. And especially if you're in a critical place like emergency departments, ICU, you're going to go from one really hard case to another hard case to another hard case, no break whatsoever. And actually, when you look from the outside, you're going to burn out doctors at twice, if not more, at the rate than you are today. So you're going to end up with worse outcomes. You're going to end up with less staff, more burned out people, more burned out nurses. So you can't win. There is no win. You're like, well, all it's going to do is now you're funding AI. You also now need more staff because you're burning out your staff at a quicker rate. So actually, it's costing you more money because you need more staff and you've got to pay for technology. And then look, like we've said before, like you bring in technology at the start, right? And then your doctors are going to have to overlook the technology at the beginning as it's being implemented.
Yeah,
They're not going to suddenly reduce the paperwork. So you're like, so now they've got patients and paperwork, and they've got to double check AI to make sure it's safe and it's okay. So now, before you've even implemented it, you've burned out doctors even more and gone, well, when they did have 10 minutes, they now only got 5 minutes because now they're double checking the AI and going, is that correct? Yeah, I think that's correct. Here's my feedback on it. And there's more paperwork to cover my ass. And then you're like, well, then what happens when it goes wrong? And GPT got it wrong. You're like, where's the physician in this? Whatever happens, they're going to get sued. If they contradict AI, it's like, well, you shouldn't do that. You can get sued. If you allow AI to go ahead and make the mistake, it's your fault. You're the doctor. You should have overseen it. You get sued. Like, I don't see how they win at the minute.
It's a little bit like that Charlie Chaplin movie, like that silent movie where he's in the factory. At a certain moment, like you can't control the factory. Yeah, wow.
There is so much gold in what Olivia just said. The thing that I think I get out of that is it speaks to the fact that we need, and it doesn't have to be physicians necessarily, but astute clinicians who understand at the heart of the interaction what it's all about at the highest levels of leadership, because they will see these things and say, oh my goodness, well, if you do this, here's the 10 negative ripple effects that you're potentially creating with this. I truly believe that in my experience, and forgive my mumbling here intermittently, I suppose my brain's going at 1,000 miles an hour because I'm so excited about this conversation. So in my experience, when you've had clinicians on the same page as the administration, it has been magic.
Mm.
Absolute magic. When that doesn't happen, it's usually a cluster, because it's like, what's the ROI in 3 months? Well, okay, that's one factor, but how does it affect these 10 other things? And physicians are really good about considering those 10 other things.
Mm.
And we underutilize that resource as we're making these decisions. So I guess that's a little bit of a plug that we need to push clinicians that are not just concerned about their own little insular desires or what their WIPM is, but they're thinking about the big picture to the highest levels of leadership within our healthcare space. And Frank, that's a departure in a lot of places, right?
It's like we're sharing a brain, because like even recently I've been on this thing where I'm like, well, when do we empower clinicians to be the leaders? You're like, don't just put them on the same path as the administrators, make them the people at the top. Sit there and say to clinicians, if you have this idea that you would like to be able to do more, well, let's empower you to take on that top role. And then it's not just you sitting there trying to persuade them to understand the front line. They have been on the front line. They're now sitting there looking after their colleagues. They're looking after what they would class as their patients, because a doctor is always a doctor at their core. That's who they are, who they identify as. So if they feel that by their actions, they're harming their patients, they make very different decisions. And they will also sit there and respect their colleagues when their colleagues come to them and say, can I talk to you just for a minute? I don't think that's right. And they talk the same language. You're already removing a barrier of going, the administrators, and look, let's be honest, bloody crap ones, which is the majority, they do a lot of box ticking, they do a lot of courses, and oh, look, I managed a degree, bloody well done. Now you're in there controlling the hospital. You haven't got a bloody clue what it's like. You've never been on the front line. Like we've seen a CEO dressed in bloody scrubs. Absolutely fucking ridiculous. You're not there seeing patients. I think we need to get to the stage where you're like, if you're wearing scrubs, it's because you're a doctor and it's because you're seeing patients. Stop sitting there dressing up and playing doctor because suddenly I'm one of you because look, I'm dressed the same. Well, okay, I'm going to dress as Batman. I'll be a fucking superhero because that's the way it is now, yeah? But we do need to get to a stage where we're like, the people in charge are the people who understand. They get it. They feel it. They will sit there and put in extra work and go, I get it. Let's talk together, because they are colleagues. They're united. This ridiculous barrier of being like, oh, do you know what? They've moved on. Let's hire another one of them. You're like, can we not? Like, it's at the stage it's kind of gross. You're like, I don't want another one of them. You look at the front line, they're like, oh God, it's yet another one. But do you know what? I get so infuriated by it. Like, I'm so angry. And I think it's even more so now with the AI bandwagon. And the physicians who stand up and go, I don't agree. Their class is, oh, I mean, you're just old. You're just stuck in your ways. You're not here for innovation, not listening to you, old timer. You're like, hold on. These people have practiced 20, 30, 40 years. Just because they're not jumping on a bandwagon doesn't mean they're not good and great doctors. They've been there, they've seen it, they've seen trends and niches and novel things and devices and tech thrown in front of them. And they're like, I know how to look after my patient. It's not because I'm not involved and I don't want innovation. I'm an old timer and I'm here with my pen and paper and I got my quill. Like, let's not do that to people. Like, can we sit there and say, just because you don't sit there in a line with, oh, well, let's do the whole AI technology thing. I think we need to sit there and go, well, can we hear them out and see what it is they have to say? But like I said before, I think it was the last podcast. It's not in people's interest financially, because a lot of these people are backing financially with their investments and stuff, the technology. It's not in media's interest, government's interest right now to push the human connection forward. Yet you ask anyone, and Todd, like you're in there now, that human connection is the core of healthcare. It's everything. It's that hand on your shoulder going, I'm here. Like, I'm here for you. It's that, and Todd, I agree with you. I've actually heard a few doctors be like, I've prescribed time out or a weekend with your wife. That's not AI,
Yeah.
And you're like, that is true healthcare. Healthcare is sitting there understanding people and needs and going, I get you. It's just even sometimes just going, I get it. I'm here for you. Let's talk about it.
I think what you're speaking to, Olivia, is the angst behind the direct primary care movement, and there's, it goes wider than direct primary care. There's direct specialty care, there's occupational therapists and physical therapists and other medical professionals and allied medical professionals that said to themselves one day, instead of trying to convince them that there's a better way, I'm going to go out on my own and I'm going to have a 45-minute session with my patient or my client, and I'm going to have a pad of paper and a pen, and I'm going to do my thing. And I think there's challenge to that idea because it doesn't seem scalable. But I'd equate it to something that we do fairly well in the United States, which is the farmers markets, it's farmers markets. So there isn't a national farmer market system. The farmer markets are local. But what works in a local farmers market is replicated over and over and over the place and all over the place. So I think there's something to be taken from this direct primary care movement where a physician goes from having, I don't know the exact numbers, but goes from having 850 to 1,000 patients to having 300 patients or 350 patients or something like that, and has time, has space, works for their patient, not for administrators, not for medical insurance businesses. And they all have this like massive sigh of relief of, wow, I can practice medicine. I can still make a living. Patients are much more satisfied. So I think there's something to there. I know it's not a panacea, but I think this move to directly say, why are we trying to romance the middle people? Why don't we ignore the middle people and create an interface that's more direct? I think there's something to that.
There's a lot in what you just said there, Jason. I think direct primary care is definitely part of the solution, if you will. I'm not sure it's the entire solution. I think there's a lot that could be said for how can we create better healthcare delivery within communities, frankly, is a notion that I'm hearing a lot of, if you will. But I think there's also the power of the collective. And if you look back historically from the late 70s to mid 2000s, if you will, maybe a little bit later, the increase of clinicians is about the same. Like, the increase in administrators, though, is like 20x.
Wow.
20 times the amount of administrative folks to deliver healthcare. There's a disconnect there, and there's a lot of waste that goes on in that layer, right? I'm going to shift gears perhaps just a little bit because we could talk about some of these things forever. I think the power of the collective has a lot of opportunity in transforming healthcare. Zev Newer talks about humanistic rebels. There are hundreds of millions of people who are frustrated with the existing infrastructure in the United States. And if we go beyond that, there are billions of people who are frustrated with healthcare delivery around the world. And how can we take those individual voices and facilitate change, right? And I'm going to speak about an interesting project that Medicine Forward is spearheading. I won't get into Medicine Forward. It's about 400 or 500 positive change agents. A good percentage of them are physicians. But we're driving a project called Prescribe Hope, which is a deep dive audio documentary into the mental health decay, the suicide rates, the depression in clinicians, not just physicians, but top to bottom. And the goal is not just to talk about the problem, but to build towards activation and getting safe haven initiatives in all 50 states, mirroring what's been done in Virginia successfully by the Medical Society of Virginia. This is an ongoing project that, if you think about it, right, not every patient can do a podcast or change policy, but they could skip a coffee and donate $5 to a project like this. And a project like this has a potential to change millions of lives in a positive way. And it has nothing to do with technology. It has nothing to do with AI. It has to do with improving the trust that has been eroded between the doctor and patient so that clinicians are not taking desperate measures to escape what is the perceived pain that they're in.
It also feels like there is now a sense of ownership, like a sense of contribution.
Yes, 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 yes. That's a perfect way to describe it.
It's funny. It's not funny, but it's in the Netherlands. We have, there are clinicians that try to separate themselves from the current ways of healthcare. So in the Netherlands, it's a lot about the insurance companies. Everything they do has to be evidence-based. Everything they do has to be time limited. It gets worse and worse and worse. It's all in bounding boxes. Everything has to be in bound. It's like being in a factory. It's like being a factory worker where you have to be as fast. It's not that different from somebody packing stuff in an Amazon factory. I mean, it almost feels like the same way.
Mm.
And you see clinicians trying to break away from that, being independent and but the funny thing is that what you also see is that more and more patients are actually willing, in the Netherlands at least, to pay more for that kind of healthcare, which is actually considered special, but then it should be normal. To have that extra time, to have that extra dedication, to have that extra ownership and hope, and which is, to me, very paradoxical, but also understanding it, to say, okay, you know what, I want to have healthcare back, then in this country I have to pay more, then let's do it.
John, I'd like to jump in and actually ask Claudia, because obviously you're a patient advocate. You obviously do a lot of work with patients. Like, where do you sit on this? Like, how far would patients go to be able to enable this, what they're talking about now?
I mean, far. Clearly they're hiring me. I mean, this is the thing, is they are desperate for somebody to care, to feel like they care, because I don't, and I tell them all the time, contextually, your physicians care. I don't know anybody who's like, I want to go into healthcare to hurt somebody, or I want to go into healthcare to not care. I mean, everybody's going into this field with a caring, compassionate heart, most all. And so they don't feel like that's not the experience they're having. And so they are desperate for somebody to walk them through this complicated mess and feel along that path that somebody cares. And so like when they text me and I text them right back, or they call me and they're like, hey, can we hop on a call? And I say yes. That's a level of attentiveness and access they just can't get in the current system. And so they want this, and they obviously, direct primary care and other concierge type services are thriving, and so there is a market for it. And to just piggyback on what's been said, I just got back from a business event in Austin, and one of the speakers was the founder of Comic-Con. I know nothing about comics. I don't enjoy comics, so that's not the point, because I don't ask me any questions about comics. But
Awesome.
the point was the inception and development of that movement was fascinating, because it was what you all just said, which was, how do we start a collective? Like, instead of, and it actually made me shift a lot of my thinking just listening to him, because instead of, he ran the movement, but he really didn't run the movement. He was like the leader that was following his followers, like this is what they wanted. And so he gave them what they wanted, and he gave them a voice, and he gave them a safe place to enjoy the things that they enjoy when they didn't feel like there was a safe place for that. And so, a lot of us are like banging our heads against a wall with the hierarchical top, which is C-suite execs and what we're trying to make these people care at the level that we already know the frontline cares. And we can't do, like, why would we do that? Why don't we just start from the people who already care, the providers who care, the patients who are wanting that relationship? Like, we've got this Comic-Con like movement ready to go, but we're like, let me just continue this conversation with the CEO.
Do you know what? Maybe you just need to bring, it's like I said to you before, what if you stop the divide between patients and the clinicians? Because there seems to be this, the clinicians class it as, oh, the patients are not looking after themselves, and there's so many and they want so much and they're just not there. And then the patients are sitting there going, the clinicians don't care and they're just too busy with themselves. And like, do you guys realize you're both on the same page? You just haven't spoken to each other. You're actually fighting for the exact same thing. More time, better outcomes. I'm frustrated. Can we get this done? Can we stop going around in circles? You're actually saying the exact same thing, but from other sides of the curtain. And you're getting so frustrated with each other, and you blame each other, and you're like, why don't you just listen? You keep coming back, and you're like, because you're not listening. But if you unite these two and you say, let's put you guys in a room, okay? Talk to each other. Nurses, doctors, everyone, because even doctors and nurses, they're side by side, but they still don't get each other's pressures. There's still that little bit of a divide going, oh, yeah, but I mean, you're a doctor. I mean, you're this. And you're like, no, let's bring everyone together. Everyone, including people like cleaners and people that you don't realize, but they overhear all your conversations. And they're just there and they're like, oh, I'm just in the way. But you're like, actually, play a really crucial part in all of this too. Bring everyone together and say, you all matter. And actually, if you put all them voices together, that's where you start the movement. Because you go, well, now it's all of the staff, well, the clinical staff and their care teams, and all of the patients versus administrators. And you go, well, now let's try and push and go, well, now you can't really do much because we're all shouting from the same song sheet here. We're absolutely united and we support each other. You've got clinicians supporting patients and going, we get it and we're fighting for you. And you are vocal about it. You're actually sitting there going, I'm not going to shield my feelings and my thoughts. I'm going to tell you straight up what's happening. Got another 40 patients here. I'm doing my best. This is what's happening. And patients sound frustrated today because I feel like you don't care. And you empower patients to say it and vocalize it and say, don't, badmouth them with the curtain shut. Talk to them and openly say, I'm frustrated. It feels like you don't care. And I'm frustrated that I'm going around. And you're like, come together. And then everyone says to the C-suiters and all that, we have to change because they're all fighting against us now. But at the minute, the administrators are very happy because they're distracting each other. Patients and clinicians are just fighting each other. And they get so distracted that neither have the energy to then fight who really can make the changes, But that's just my view on that bit.
I think that's wonderful. And I think it speaks to the fact that there has to be give and take between these organizations and these entities. It can't just be it's my way or the highway. We've all got to learn to work together in a unified manner, if you will, to push some of these initiatives forward. And I guess it's top of the mind because I keep going back to it, but that's why we're trying to be very inclusive with this project. Like I've spoken to physician organizations, pharmacist organizations, nursing organizations, patient organizations, individuals. We're trying to get all of these entities, not necessarily to be driving the ship, but to agree, yes, we want less clinicians killing themselves. I think everybody can agree to that. Let's all say, yep, thumbs up, let's move forward, let's make it happen, and let's drive these numbers down. In my mind, this is just an example of many things that could occur if we can accomplish what Olivia is saying, which is to unite the patients and the clinicians instead of arguing about things, saying, look, nobody's happy with this. Let's make some change. And here's how we can do it,
I feel compelled to add something to our conversation, and I'm taking this from a fairly recent Time Magazine article, and the punchline of the article, it might be the last line of the article, is health is what happens between doctor visits. And I think something I want to add to the conversation is everything could be operating extremely efficiently, but if we're overwhelming the medical system with ailments, it maybe even the most impressive efficiency couldn't keep up with it. And so I think part of the solution to this problem are things like, how is wellness and sickness approached in families, approached in churches and synagogues, approached in schools? What kind of efforts can be made at prevention, at reducing the demand for medical care?
Oh, now you've touched upon a big subject that I keep talking about at the minute, because me and Mark, like we did a podcast together, right? We were co-hosts on it, and we went through this thing. It's like, well, it always came back to the biggest solution is preventative care, public health and stuff, but that goes into education, society, housing, all these things. And you're like, I mean, it's like asking for world peace. Like, it's become so big now. You're like, God, we can do this. Like, we can make miracles. But it is there. And one of the other co-hosts, she was like, well, it's really difficult because you can't limit the money that's going into sick care right now. Like, it's absorbing it all, so you can't cut the money. But yet going into preventative care and that kind of thing takes money too. Like, and you can't see a return on investment for 20, 30 years, if not longer, because you're starting at such a young age. You know, you're educating them from really young ages. And you're like, well, you're gonna have to wait until they're 30, 40, 50 to see that they don't have dementia and obesity crisis and all these things. And you're like, you know, heart disease in men. And you're like, it's so difficult because they want, yeah, but what happens in 3 years, 5 years, or even 10 years? And you go, well, preventive care is going to cost you a lot of money for multiple decades before you can see in healthcare that we're actually now reducing all the costs that are going into the sick care. So do you know what? It's a really big thing. I'm glad you actually brought it up, because I think it is the future, and everyone who's in the, you know, lifestyle physicians and all that, I'm like, keep going. I like, don't stop just because it's tricky right now, because this is the future. Like really like put your efforts into this. But it's also really hard to be like, yeah, but you're going to have such a backlash because people aren't putting money into this. Investors aren't. So I'd be, especially for Todd, I know you just put your finger up. I was going to throw it to you and be like, because you're obviously a practicing physician at the minute, what are you seeing? What's your thoughts on this from your perspective?
I think this is brilliant, but I think there are innovative ways to actually accomplish it, and potentially in conjunction with the work that Jason's doing. And I think DPC is a perfect example of this. I think if the employers start to realize it, you know, if they have a DPC model with, you know, let's say a catastrophic insurance plan on top of it, as opposed to a traditional plan, you're going to cut out a lot of fat, and you're going to have a lot of savings very quickly. Typically 20 to 40% savings when employers start to create a model in that regard. And so that's one of the projects that I'm currently working on in my role, is to try and facilitate some of this down the road. Not immediately.
Do you think the money,
it works?
sorry to interrupt, but do you think the money that they save, so say they did that, do you think they'll put it into preventative care and that kind of thing? Or, you know, because obviously the crisis in multiple countries is like lack of staff, you know, they don't have the money for the updated equipment stuff. Are they going to, if they did cut the kind of middle management and administrators, are they just going to, because of habit, just fund more sick care? Or do you think they'll sit there and go, with that saving, we're going to go into prevention? Or are we then going to see society and people blasting them and going, yeah, but I mean, we're still understaffed with sick care and we still have waiting lists and they're funding this? What's your thoughts on that?
That's a great question. And I think it'll depend on who's driving the ship. If you have the person driving that ship at the highest level of big, let's say, insurance carriers, yeah, I think it probably could go into what you're talking about. But I think there's entities that are going to spin it a different way to utilize those savings to pour that back into the community to keep people out of the hospital. I think the people who truly get how this work are the ones that should be driving these ships or these projects. And not only will it lead to, I mean, you can see it over and over again, it leads to better outcomes, lower costs. It embodies the quintuple aim, right? The patient experience, quality care, lower cost, provider wellness, but also that health equity piece. It has me thinking of some work a friend of mine, Mark Smiley's doing in North Carolina. And it's Beyond Equity Group. He's an emergency room physician who has a nonprofit and a for-profit group working on buying not old, but let's say properties that need significant restoration, fixing them up, connecting the dots, better housing for the individuals that need it, leading to less ER visits. It's a fascinating project, and I am not doing it justice with my explanation right now. So look up Mark. He's doing some amazing work. He can explain it much better. But it's those little projects that, if we can say, hey, it works, and here's an example of it. And this goes way beyond just healthcare delivery, right? I mean, we're getting into the equity piece, the housing piece, the food security piece, and all those other isms that are causing problems. So to answer the question, I think if we have the right people leading these initiatives, it can work.
I have another question.
Oh boy.
So I'm going to throw it out to all of you again. I totally agree with you 100%, right? So this is a big question now. How do we get them people in the top position when currently, excuse my French, absolute assholes are currently in the positions, and they just know to hire more assholes, right? They don't want to rock the boat and bring in the really great, they're going to rock the boat, innovative. How can we now, because we're all on the same page, bring more of those people into that position now and say, look, we're not talking 10, 20 years. We're talking as soon as possible. How can we get them up there and start getting rid of and preventing the assholes getting in the way and saying, we don't want them anymore. We want the good. Who's going to do it? Because what I see, and Mark, it's probably a bit different in the Netherlands, same as it is here, but you guys in the States, there's so much money funded by insurance companies and that kind of thing. Is a lot of money back in the kind of who's going to be in charge of this, So I'd just like to know, like, how can we get them to them positions?
I'll jump in here. I've got two thoughts on this, I suppose. I think one is with education, and I think social media and documentaries and other platforms. You look at an individual like Dr. Glaucoma Flecken. I don't know if you're familiar with his work.
I love him.
He's hysterical. He is hysterical. But I would love to use the power of his platform beyond the educational and humor that he delivers to help get to connect some of these activating projects to that. I think that would be magical. So I think that's part of it. And then I think about other groups like Doctors for America that has about 27,000 members associated with it. One of the founders is the current Surgeon General of the United States, and he obviously has a lot of influence. And I think if we can continue to get traction with groups like that and get not just clinicians, but physicians ideally in some of these leadership roles and further up the food chain, and perhaps it's in politics. I'm not advocating that I want to go into politics necessarily. I think I swear too much. But I think that's another piece of it, right? And so I think education and policy change can accomplish this. Now, Olivia, don't get me wrong. This is not going to be like flipping a switch. We've got a mountain of obstacles ahead of us. However, we have 329 million people in the United States, as an example, that I think would back these initiatives. And how do we reach those? And how do we get them on our side? And
do
when
you
we
think
can
we have
do
time,
that,
though?
before
So when
it
you look
implodes,
like over the next 8 to 10 years, so this is why I say, like, we're against the clock in a way, because the prediction is with the amount of med students that are saying, look, I'm going to finish med school and not ever go into clinical work, as we heard in one of our podcasts, versus how many doctors are also retiring, how many are now going into portfolio careers. Like, the prediction is in 10 years' time, we're going to have like less than half of what we have now. They're not going to be there. There's hardly anything to say. So you can go, let's do policy change and we'll start with a bit of education, but you're like, I know it can't happen overnight, but it also can't happen in 10 years' time. There's nobody left really to be able to help. And that's when, me and Mark have spoken about it before. I mean, when AI and tech, we're fighting that actually at the minute, because their argument is going to be, well, we have to come in because you guys aren't going to be here. And you're essentially making this come true just because you can't help these people quick enough.
It's kind of funny because in the Netherlands, it's actually the case that a lot of physicians, like medical specialists who have like, I don't know, 10 to 12 years of training, they can't find a job. Because in our hospitals, there is such a, the physicians, they either employed by the hospital or they buy themselves in, like they're an independent company within a hospital. And so they keep the numbers very small. So we have a lot of specialists who just can't find a job. So the Netherlands, there's not a shortage of supply. But the funny thing is when you say, okay, how can we put the right people at the right place? How can we place them there? And I'm like, okay, but then it brings me back to what Jason was saying. Like, okay, do we really want to change the system? Or do we just want to say, okay, you know what? This is not going to work. Let's build something new. But sometimes it's just better not to refurbish a house, but just to knock it down and start again. And so
I'll bring the bulldozer.
For me, I see a lot of power. I see a lot of power in the collective. I do think there is a place and a time for technology, but I do think it will never surpass common sense. It won't surpass certain common sense policies on prevention that don't need a model or anything, just to know that it's going to be good. So for me, the way that I see it is, have these initiatives where the physicians take back the caring, support them with technology for a certain amount of things that need to be done, because we do live in a digital world. I mean, nobody wants to go back to 200 years ago. And then bring that from the collective. And like, if you can bring clinicians and clinician physicians and the patients together, why do we need, let's go even on a limb, why do we need insurance companies? Like, why do we need the current system at all? Like, I mean, it's there and it's bulking and, but if it's not working.
You're going to leave me thinking about this for far too long.
Do
you know what? I've never thought about it.
What Jason was saying. Like, why? I mean, that's vision, that's vision. Vision is something that it's not there and seems almost infeasible. But that's also the fun part, I would say. That's when when it sounds almost infeasible, but it's necessary, then you know that you have to break the current system. You cannot come from the current system.
Joe, I'd love to hear Todd there because that is ruminating in my head. And you guys, obviously, it's so heavy in the States with insurance. And obviously, as a physician, you understand that so well. What is the answer to that? Why on earth do we have insurance companies?
Oh boy.
We're going to go down the rabbit hole here.
No, not. I'll try not to take us too far down the rabbit hole. I think there's a place, but I don't think it's as it stands. I think the role should be significantly reduced. And I think we could come back to, the concept of DPC and working with employers and what's the role of insurance there. The key players in that model are the patients, the employer, the physician. Those are the three key players in my mind to that model, right? The employer funds a lot of it, but then as a backup, put a little bit of money into a pot for the catastrophes, as a backup plan. But that's not what exists currently. Currently, everything falls under the insurance bucket, and it's so driven by doing things instead of preventing things that we're in this mess that we're in now. But I agree with Mark. Blow up that model and let's try something different. And then when we've sort of got it figured out, and I think there's some groups that are getting closer and closer and closer to this, then we scale it. Then we scale it. Then we have the policy change follow along behind it. And to be honest with you, 10 years might be a little aggressive in a timeline. But the other avenue that we're going down, we can't do that. We can't have clinicians continuing to kill themselves. Frankly, with the existing infrastructure, it's killing people for lack of access or mistakes or lack of transparency. So yeah, I that was a long-winded answer and probably touched on a couple of the questions in there. Hopefully it was cohesive. And if not, Claudia, I pray you can just edit it out.
See, it's tricky though, isn't it? Like, with the insurance thing, and I always go back to like the NHS. So in the UK, you got NHS. We're not an insurance-based healthcare country. It's not. It's funded by the government. And you're like, well, when you look at health insurance there, it's so that you do have luxury care. You're talking the best of the best and you go to lovely places and it's wonderful. And it's absolutely optional. You never have to have health insurance. And if you've got cancer and you need, medicines, or you need the best care and you need to go to these perfect hospitals with the best doctors, still doesn't cost you anything. But the system is still so broken and still so damaged. And I would say, like, whether you're in the UK as a physician or the US, you have the same arguments, you have the same pressures, the same situation. And you're like, where's the expectation that's put on you guys? It's the pressure and the long hours and the abuse and all these things. And like, it doesn't matter if you're funded by insurance companies or governments, whether everyone can access it or only the elite can access it. It really is actually the same problems going round and round in circles. But then I look at Ireland with the hybrid system, part private, part NHS in a way. And you go, well, over here, nobody can agree. They go, well, yeah, insurance is the best way of doing it. And then the other half people go, yeah, but no insurance is the best way of doing it. And I go, do you know what? It's because society, we expect everyone to fix everything. It's now, it's all immediate. Fix me now because I haven't looked after myself. Do this for me now. Be quicker, do more. And you sit there and go, no matter how it's funded, that can't be done anymore. And then the more you burn out doctors, the more there's errors. And then you go, see, look, doctors are error prone, nurses are error prone, need to bring in AI to stop that. And you go, stop being silly. Just stop putting so much on a human being. You wouldn't do it with any other industry, but you feel that you can do it with these people because they will do anything for somebody else's life. They have a life in front of them. Like, put somebody's life in front of anyone and go, what would you do to save their life, to make them well, to stop pain? Well, these people do it for a living every day. So of course they're going to be able to be pushed harder than anyone else, because you're putting another life in front of them and going, I know you're tired and you've done 30 hours, but somebody's life in front of you is worth more. They're in pain. Can you go an extra bit? And they go, yeah, I can. I'll do it. It's all right. I'll catch up on sleep another time. Don't worry. I'll hold my bowels. I'll do that. And you're like, that's the punishment. And that happens in the UK and different countries and the US. And you're like, can we stop that? And then I see the conversations now with clinicians leaving. And I'm like, they're just getting abused in industry now and corporates because they take advantage of them because it's their personality. They're used to this attitude. They're used to people saying, give me more, do more with less, and don't complain. So now industry take advantage and startups take advantage and go, oh, we don't have to pay you because look, we're helping patients. You're doing good, help us. And you're like, you fuckers, like, this is ridiculous. And it's that. So how can we stop the mentality even and say, insurance needs to be an absolute zero profit, not a not-for-profit in the, we'll still take money. But, there is this, like you said, Todd, like there's this pile of money and it funds things. Maybe we do need to take responsibility and everyone does put money in, whether it be, comes out your own taxes or whatever. We should contribute. Governments can't always just do it by themselves. We have to do something. And I think we should put a little bit in, but I don't think we should be putting it in for the executives to take out their big multiple bonuses and we're sitting there not being able to pay our bills. Like, there's got to be some kind of mid-ground where insurance isn't the way it is today. And maybe it's even called something different, Rainy day fund.
I think there's something there, Olivia, especially because there's this idea, I think in the United States, at least since World War II, with the offering of medical insurance through employers, that it's free, right? That it's covered, that it's taken care of. And I think there's I don't have this thought fully formed, but there's something in that diffuse idea that creates a lot of baggage. Whereas when it is more direct, and I think there are attempts, and some of you all might know more about this than I do. And I think a lot of the direct primary care physicians encourage what's called a health share here, which isn't considered insurance. And it is, as I understand it, it functions a lot more like a pool with a lot less bureaucracy in it. I think where that gets interesting is when it's more transparent and when we know what I'm paying and what I'm paying for, and there's just less muddiness in the middle. I think I'll say this directly. I think everyone behaves better, or everyone is their inherent humanity has a chance to shine, because we're not sort of playing games. I think a lot of the layers and layers of medical insurance create sort of games, right? Will this be approved, and will there be a copay, and what will the change be next year, and all that kind of thing. So there is something to be said, I think, for this more direct making direct payments to physicians and other medical professionals, and also something that is like insurance being simpler, for sure.
I think those models definitely bring in transparency and also aligned incentives. The individuals that are putting money into there, they're paying attention to where the money's going. the lack of transparency and that it's just quote unquote free. Well, we're all paying for it. 20, nearly 20% of the GDP in the United States goes to healthcare. That's insane. That's completely insane. And our outcomes suck, frankly. And our life expectancy, although it's ticked up recently, has successfully been bent in the negative direction, unlike every other developed nation in the world. So I agree. I think those kind of models are potentially part of the solution too. They bring in transparency. They help align incentives. They put the patients back into the driver's seat in some of these situations. I think they're brilliant.
I think one bit I actually forgot to mention before. So something Ireland have, my husband worked for is a company called VHI. It's called Voluntary Health Insurance. It's a health insurance company. It's owned by the government, which seems crazy because they also do, public health and everything. And there's that free thing. But it was something that started so many years ago where people could pay for insurance and they paid for private care. It did that. And the hospitals here, you could pay, privately if you had, health insurance, you got faster care, you got better medications. And if you didn't, next door, you would have people that didn't have health insurance and they were still getting their care. And it kind of worked. That's why I say it's a bit of a funny thing because it's government owned, they can't make profit. So if, for example, they make too much profit and they didn't pay out enough each year, they have to give the money back to everyone. So they have to sit there and go with all the profits. Now, every single person who paid for health insurance gets a check. And they do that. We get that and we pay, I think, about 1,500 a year each. Me and my husband, my children are 500 a year each. And it covers pretty much most of our healthcare. We have 2 weeks and we get to the best hospitals. It's all covered. And then for the end of the year, they manage to make too much profit, they give you a check. If you end up doing really good stuff, you got a smartwatch, you do loads of exercise, they'll send you gifts. They'll say, look, you're looking after your health, you're exercising more, you're healthy eating, you're doing all these events. We're going to send you gifts. And the more you do throughout the year, the bigger the gift is going to get. Now you get a water bottle. Now you get, a ticket to a holiday and you're trying to do these incentives. But like I said, even with that, and you go, that's a pretty good idea, insurance isn't too expensive. But yet there's still this divide of going, yeah, but it still doesn't feel fair. And I argue that out of all the systems I've seen, I feel Ireland is the most fair in that regard. Because you sit there and go, you are paying a reasonable amount. It doesn't kill you. It's not taking like you guys, like 40, 50% of how much you earn just goes into your health insurance. Like, this is craziness. But I look at that and I go, I quite like that system in a way. And I know people argue about it, but I'm like, yeah, you can still get free care. You can. If you go to our emergency room and you go, well, we have no income or in low income, like, but that's free. That's free. Go ahead. That's fine. If you have an income, well, they're going to charge you like €100, so about $90. Now all your care's covered. You've paid for that. But there's a barrier to be like, well, you can't just come because you've hurt your foot. It's going to cost you if you're earning, So there's this little bit of a barrier that says, pay for that, you should. Our family practitioners, you pay for that. They're private. Like, that's the way it is. But if you have no income, that's free for you. There is no barrier. So like everyone gets care, but you get different levels of care. Like, if you get cancer, look, don't worry about your private health insurance. It doesn't matter. Like, go into the public system, they're going to look after you. It's fine. And you're covered again. And you're like, well, that feels like it's fair to me. And I'm like, well, if I could take a little bit of that and put that into America and say, no, well, if your health insurance companies and make profit, you sign a check and you give it back to everyone and say, John, we didn't use all that money for our care. And yes, we've got a bucket for, making sure that everyone's covered. But this is a check back to you guys. We didn't need it. We over budgeted. There's a check for you. And the NHS in the UK, and you say, why don't you build a government health insurance company and allow people to pay in for it? And then it's not just coming out of your pockets. People are contributing to their healthcare. And I just think there's maybe this little bit of a mid ground that we could maybe learn from that says, you don't have to profit from this as a health insurer. You can give back and be sustainable. The proof is here. This has been here for decades. And our health system is not on its knees right now. And to be honest, we don't have physician suicides here. We don't have that. That's not something that happens. And yeah, they're pissed off and the system is broken, but not to the level that I'm seeing from other countries where I'm like, they really are on their knees. So I'd like to see, maybe would it be something that could work in these different environments?
Really interesting. I think this has been such an amazing conversation, and I really don't want it to end, which is a good sign. You know, and there's one more element to this that I'm seeing on the patient advocacy end, which is most all of my clients don't even want what insurance is willing to pay for. What they want is, I don't want to go to an oncologist in America. I want to go to Hope for Cancer Center in Mexico. What the things that I want, insurance doesn't pay for anyway. So what is the point? You know, like, yes, there's a role. There's, like, you know, obviously trauma, emergencies, surgical needs that Western medicine does extremely well, but they want acupuncture, they want Reiki therapy, they want to seek other options, because, to be quite frank, our options here aren't working fantastically well on a large scale. So that's could be its own discussion, I know, and I know we're already 6 minutes over. I want to tell each of you how appreciative I am of your time and insights, and I think this is so valuable. I want to end with allowing each of you to sort of say whatever your last piece is about either a final insight and or how people can find more information on the work that you're doing, links, whatever you would like to share. So we'll go in the same order. Todd.
Oh boy, I could stir up a lot of trouble with just a short snippet here, I suppose. I'd like to maybe plug two things, if you will. And one of them is I'm just super proud of the book that I wrote with a patient called Ripple of Change. The website's being redone. That's ourquadrupleaim.com. But I think more importantly than that is the Project Prescribe Hope. I really believe this is an opportunity to unite clinicians and patients on a unified endeavor to really make some big systemic change. And there's a couple ways you can check that out. Prescribehope.org is one, or medicineforward.org is another. And I'm on LinkedIn all the time. If you direct message me, there's a good chance I will get back to you somewhat expeditiously. And I really thank you for having me on this panel. It was a lot of fun.
Amazing. Olivia, who would you like to create yourself to be today? Where can people find you?
I'm Batman. No, do you know what? I don't really have any of these kind of like, oh, magical thing to end on. And you know what? Like, people that know me, look, you're gonna see it. I'm on LinkedIn. You can reach me wherever. But you know what? I just want to highlight everyone on this panel, because I know I haven't personally spoken to you, Jason, but I think this conversation has been so important. All I want all these listeners to do is keep this conversation going and make sure that your voices are out there and we're actively talking about it. Don't just think about it. Don't feel like you're on your own. Use your voice and actually speak about it. Let's make people aware of who we are and what's really important in healthcare, and just keep this conversation going and going and going. And look, if you can join groups, podcasts, and share this, then do that.
Lovely. Jason.
You know, I think I'll take a chance to what I try to do on a weekly basis, advocate for the profession of wellness coaching a little. And what I want to share with people is, if you know you need to be eating better, you know you need to be exercising more, you know you need to be taking better care of yourself, and you look at most of the medical system and conclude they're not helping me with this. I get that. I want people to know that since 2013, there have been board certified wellness coaches. So we are essentially an emerging allied medical profession. We will probably not be mainstream for quite a while. But if you say to yourself, I want to solve that problem, I can't do it by myself. There are people like myself who will work with you for a period and help you finally solve that problem that you might have had for years or decades. And you get to live with all of the reduced risk that comes with a salutary lifestyle. And the important thing I want to emphasize is you can get help with that. There's more than just you suck it up and do it by yourself. You can get help with that, and help helps.
How can they find you, Jason?
I'm my full name, Jason Gutman, on social media everywhere. So that's fairly easy. If they want to go direct to my website, my business name is Puvema, Puvema, and puvema.com is the website.
Lovely. All right, Mark.
Yeah. So wow, what a what an interesting talk. I mean, could go on for ages. So, but Olivia said you need to be honest. I knew it wouldn't disappoint. So thank you for that. For me, it's yesterday I was asked, if I'd like to be out of a job because I work in technology. I'm a data scientist. I'm a modeler, but I don't have the traditional technological hype kind of view. I like humans. I like the collective. I like the symbiosis between human-centered thinking and common sense, and then having technology and seeing how that supports. So that's what I do in all the business that I do as an independent data scientist, to see, okay, how can those things come together? And sometimes they don't, and that's also fine. But at the end, we shouldn't be looking for ways to appease technology. It should be the other way around. It should always help us, should not define us. So, I mean, that is something that I always advocate about. That's always what I strive, towards, communicate towards. People can find me on LinkedIn mostly. If you want to find me, then it's best if you, if you Google me and just type in Dr. Mark Jacobs. That's not because I'm so fond of my, PhD title, but if you type in Mark Jacobs, you will find another guy who also works with models, but it's quite different because he's a very, very well-known designer of fashion.
I always wanted you to give me a bag.
Yeah, exactly. And so that's where you will find me, and I'm quite vocal, and I'm happy to chat with anybody. So, yeah, always nice to
Amazing.
meet a new person. Yeah.
I love this group of amazing humans, and I'm so appreciative of you all coming on. Thank you so much again.
Thank you.